Okay, so maybe if you are ready, can hand over to you.
Thank you, Joe, for the introduction. Hi, everyone. I'm Yubi. I'm a medical student from Brighton Sussex Medical School. So, as Joe mentioned, today's session will be a PBL. So, we'll start by looking at a patient case and then try to come up with some differential diagnosis as a group. So, I would appreciate if everyone can unmute yourselves or just type in the chat whatever you feel most comfortable with. And we'll also cover some learning objectives. And so, yep, let's don't be shy. And I'm also learning just like everyone. So let's keep this interactive. And let me just share my screen. Can I just check if everyone can see my screen?
Yeah, we can see it in way.
Okay, perfect. So here are our partners. A shout out to them for supporting us and helping us develop these sessions. And these are the learning objectives that we'll cover today. So we'll start by discussing some key points from a patient case and try to come up with a differential diagnosis. We'll then look at some anatomy and have a quick recap of the large bowel, the blood supply and lymphatic drainage of the colon and rectum. We'll then focus on the anorectal anatomy that's important for understanding the pathology of common conditions such as hemorrhoids and anal fissures. And we will then briefly review the innervation of the bowel and how issues with nerve supply can lead to problems with motility and sensation. We will also look at some clinical application of this knowledge and we'll discuss some red flag symptoms and signs that should make you suspect something more serious like cancer versus something more benign. We'll then look at some risk factors for colorectal cancer and we'll cover some tools that we use to diagnose bowel conditions. And finally, we'll look at some current management strategies for the key conditions that we'll discuss today. So here's our case. We have Mr. Thompson here, who is an 58-year-old man who reports passing blood mixed with stools over the last 3 weeks. So based on that, what are some of the diagnoses that come to mind immediately? Again, feel free to unmute yourselves or type in the chat. I don't think I can see the chat, so Joe, would you be able to read out any messages from me?
Yeah, I'm having a look at it.
Okay, thank you.
Someone said hemorrhoids, fissure.
Yep, absolutely.
Someone said could it be polyps?
Yep. Anything else?
And Eva mentioned IBS.
IBS, yeah. There's a high possibility of that too. Do we have another?
Yeah, we have another one is colorectal carcinoma.
Yeah, definitely. Especially given his age and also blood mixed with stool for 3 weeks.
And IBD.
IBD, yep.
And Charlotte mentioned malignancy.
Malignancy, yes. So already we've got some really good differentials, but let's take a look at the rest of his history.
Oh,
Start
sorry.
with
Maria mentioned whether it could be a obstructive disorder.
obstructive disorder. Yeah, it's a possibility of that too. Is that it?
Yeah.
Yeah. Okay, no worries. So history of presenting complaint. He's noticed bright red blood coating the stool and occasionally dripping into the toilet bowl. He also reports a change in bowel habits, alternating constipation and diarrhea. He experiences occasional lower abdominal cramping, but there's no severe pain. He denies any weight loss, but he feels more fatigued lately. No fever or night sweats, and also no history of previous GI problems. So, already this is looking quite concerning, especially the bright red blood and the change in bowel habits, and his age are all red flags that suggest serious pathology. But let's take a look at the rest of his history and examination findings. So he's got hypertension, no previous surgeries, and he's currently on amlodipine, assuming for his blood pressure. And he his father was diagnosed with colorectal cancer at the age of 65. Social history, he's a long-term smoker. He smokes 10 cigarettes a day for 30 years, which equals to around 15 pack years, so quite substantial. And again, another risk factor for malignancy. He also drinks socially and works as an accountant. So occupation might suggest a sedentary lifestyle, which is also a known risk factor for colorectal cancer. On examination, his vitals are normal and there's only mild tenderness on his left lower quadrant. However, there's no obvious masses or organomegaly. On rectal exam, he does have some small external hemorrhoids, but no palpable masses or fissures noted. He also doesn't have any signs of anemia, but he does seem mildly pale. It's important to remember that clinical signs of anemia can may only appear when it's quite severe. So in patients with chronic blood loss, the patient can still look relatively well, but they can still be anemic. So further tests should be done to confirm that, which could be the case here for Mr. Thompson. So on the right here, we can see an image showing the four main quadrants of our abdomen. So my question is, what are we concerned about usually with left lower quadrant pain?
Possible that diverticulitis.
Yep, exactly. So we can think about what that region corresponds to. So it's the descending and sigmoid colon.
Mm.
That's
Someone mentioned UC, ulcerative colitis.
yeah, exactly. Anything else?
Uh, Nothing in your chat as now.
Oh, that's fine. That's okay. We can, yeah, let's look at some clinical features that we can, so that allows us to differentiate between malignancy and benign causes of GI bleeding. So, which side do we think Mr. Thompson is leaning towards? Sorry for all the questions, but I'm just trying to make this interactive.
Um, Mara mentioned benign.
Benign. Is there a reason for that?
Okay, and now Rosville mentioned malignancy. So someone asked a question. Does he have weight loss?
He doesn't. There's no. Let me just move back. He denies any weight loss, but feels more fatigued lately.
So Charlotte mentioned uh more possibly colorectal cancer due to like family history, social history, and the location.
Mhm. Absolutely, I agree with that given all the red flag symptoms that he's having. But let's look at some of the features that would make us worried about cancer specifically. Starting with blood mixed with stool, often suggests that bleeding is higher up in the colon rather than just from the anal canal, as it needs time to mix with the fecal matter as it passes. And that's a classic symptom of colorectal cancer, which is also something Mr. Thompson reported. And persistent rectal bleeding is another major red flag. And for Mr. Thompson, his symptoms have been going on for 3 weeks, and that would be counted as persistent rectal bleeding. Iron deficiency anemia um, is usually a strong indicator of chronic and ongoing blood loss. In the GI tract specifically, it raises concern for a bleeding lesion, such as a tumor like in colorectal cancer. It can bleed slowly over time without the patients noticing it, but then they gradually become anemic. So, for Mr. Thompson, he doesn't show any anemic signs, but he does look mildly pale. So that suggests that bleeding might have been happening even before he noticed it. Um, we then have change in bowel habits, especially more than 3 to 6 weeks. So any new or persistent or worsening change in bowel habits, whether it's constipation, diarrhea, or alternating patterns that last for more than 2 weeks. It will raise some suspicion. And unintentional weight loss is another classic indicator of underlying malignancy. We then have loss of appetite and fatigue. These are more non-specific features or symptoms, but of other red flags. Systemization is very significant. So already, Mr. Thompson is taking several of these factors here. The malignancy side, so it was quite concerning. Now let's compare that to more benign features. Like we have blood on paper or coating stool, and that typically points to a source in the distal rectum or anal canal. And for long-standing fluctuating symptoms, benign conditions often go on for years and they come and go rather than progressively worsen like many malignancies. And pain with defecation is a classic symptom of anal pressure, as I mentioned earlier. It's a small tear in the anal canal lining or thrombosed hemorrhoids where blood clots form within the hemorrhoids. And passing stool can stretch the anal canal, causing a lot of pain, um, which leads to pain with defecation. Next, we have intermittent bleeding and pain relief by defecation. And this symptom is more typical of IBS, irritable bowel syndrome, where discomfort of the abdomen is often associated with bowel movements and is relieved by passing stool or gas. And sorry, just 1 second. Okay, we so overall these benign features don't really fit our patient, I would say, and but on the other hand, he's taken several boxes from the malignancy side, so we should be worried and think about some urgent investigations as our next steps. And so here are some differential diagnoses, and I just want to compare them, starting with colorectal cancer. For age, it's typically seen in individuals over the age of 50. So Mr. Thompson is 58, so he matches this criteria perfectly. Pain is often minimal or absent in the early stages of colorectal cancer. And a key feature of colorectal cancer is that they have blood mixed with stool and also a change in bowel habits. For systemic signs, fatigue and or anemia is a strong indicator. As we discussed, chronic blood loss from colorectal cancer can lead to iron deficiency anemia, causing symptoms like fatigue or pale skin. Next, we have diverticular disease, which involves these small pouches called diverticula forming in the colon wall, and they most commonly affect the sigmoid colon. And it's more common in older adults. It also often causes lower quadrant pain, which matches with Mr. Thompson's mild LRQ tenderness. But bleeding is usually painless and can be quite heavy and bright red. So that's a crucial distinction because, sorry, 1 second, I lost the slides again. Yep, as I said, it's a crucial distinction because diverticular can bleed significantly, and the blood is usually bright red and less commonly mixed in with stool. So it's unlike what Mr. Thompson described, and systemic symptoms are uncommon unless there's an infection going on at the same time. Next, we have IBD, inflammatory bowel disease, which often presents in younger patients, and usually there's a second peak later on in life. And pain is often described as a crampy abdominal pain, and patients often have bloody diarrhea and systemic symptoms like weight loss, fever, and anemia due to chronic inflammation and malabsorption. Next, we have a very common condition, hemorrhoids. So it can affect people of any age, but they are usually painless and unless a blood clot has formed within the hemorrhoids, which we call a thrombosed hemorrhoids. and or when it's severely prolapsed. So bleeding is typically bright red and it's often seen on the toilet paper or dripping into the toilet bowl. And another important distinction here from Mr. Thompson's symptom is that hemorrhoids generally don't cause blood mixed with stool, but usually it's coats just like the outside. So it can be unlikely the case here for him. There's no systemic signs unless there is extremely severe and prolonged bleeding, which is rare. And finally, we have anal fissures, which are these small tears in the lining of the anal canal. It can occur at any age, but these are often seen in young adults, and they cause severe and sharp pain on defecation, with a small amount of bright red blood on wiping. And again, systemic symptoms are usually absent. So it's clear that while blood in stools can stem from various causes, Mrs. Thompson's features and risk factors point us strongly towards colorectal cancer, I would say, given his age and his symptom of having blood mixed with stools. Systemic signs like a pallor and also fatigue are all significant red flags. And he also had a strong family history of colorectal cancer and also a substantial 15 pack year of smoking history. And these factors all place colorectal cancer at the top of our differential. Please feel free to interrupt if you have any questions. So now I want to talk about differentiation between upper and lower GI sources. So I'm sure a lot of you have come across these terms already, so this will just be a quick recap. So when a patient presents with GI bleeding, well, the first things we want to ask is that is this coming from the upper or the lower GI tract? And the appearance and the color of the blood actually gives us a lot of clues. Starting with hematemesis, meaning vomiting blood. If it's bright red, then it suggests fresh bleeding, meaning the blood hasn't been in contact with stomach acid for long, or it's a very rapid bleed. But if it's dark and granular, almost like coffee grounds, then it means that the blood has been partially digested by stomach acids. And this points to an upper GI source, like bleeding from the esophagus or the stomach. Next is melena, which is a black tar-like smelly stool caused by digested blood, and this usually comes from the upper GI tract because the blood needs time to travel through the intestine and to be broken down. But rarely, very slow bleeding from the right colon can cause melena too, but it's usually from an upper GI source. Next, we have hematochezia, which is the passing of bright red and maroon blood through the rectum. It's often mixed with stool, so this color indicates that the blood hasn't been significantly digested. And when it's mixed with stool, it suggests that the bleeding is occurring within the colon itself, and this points towards a lower GI source, like the colon or the rectum. However, if someone does have a really fast, massive bleed, like an upper GI bleed, then the blood can actually rush through before getting digested and come out as red as well. And finally, we have occult bleeding. Occult means hidden or not visible to the naked eye, but they can be picked up by stool studies like a fecal immunochemical test or a fecal occult blood test, which we'll talk more about later. And over time, this can cause iron deficiency anemia. So which one of these do we think Mr. Thompson have? Joe, are you here?
Yeah, hematochezia.
Yep, exactly. So he's got blood mixed with stool, which also supports a lower GI source, and that's really important to decide which investigation we should start with. So moving on, I want to talk about some risk factors for colorectal cancer. Starting with some non-modifiable risk factors such as increasing age, often after the age of 50. Family history and genetics are also important, especially if a first-degree relative has colorectal cancer. Modifiable risk factors include diets high in red and processed meat and a diet high in low in fiber intake. And Heavy alcohol intake and smoking are also linked to an increased risk of colorectal cancer. Type 2 diabetes and inflammatory bowel disease is also associated with a higher risk, likely due to metabolic and inflammatory effects. Having a sedentary lifestyle and being overweight can also be a risk factor because it increases inflammation and also insulin resistance, which can promote tumor growth, and that leads to development of cancer. So now we'll just have a quick recap of the large intestine anatomy. So the large intestine begins at the cecum, where the ileum joins via the ileocecal valve. From here, it continues as the ascending colon, then becomes the transverse colon crossing the abdomen. It then bends and continues downwards as the descending colon. And this leads into the sigmoid colon, which is mobile and S-shaped. It connects the descending colon to the rectum, and we then have the anal canal there. And we also have the appendix arising from the posterior medial wall of the cecum. So some of the features of the large intestine are both clinically and surgically important, as they allow us to distinguish the large intestine specifically. So first we have these haustra, which are these bulging pouches that give the large intestine its segmented appearance. So they are some of the key identifiers on imaging and also during surgery because they help to differentiate from the smoother small intestine. Then next we have tinea coli. These are longitudinal muscle bands. There's 3 of them that run along the outer surface of the colon, and which is what creates these haustra. And the tinea coli is also an important landmark for locating the appendix because these bands converge at the base of the cecum and at the base of the appendix on the cecum. And so during surgery, the surgeon can just follow the tinea coli and it will lead them to the appendix. Omental appendices are these small and fat-filled pouches of peritoneum that's attached to the colon. They don't really have a major role, but it's potentially for cushioning the colon and also fat storage. Next, we have hepatic flexure, which is like a bend that's located on the right side beneath the liver, hence the name, and where the ascending colon bends and becomes the transverse colon. On the left side, also, we have the splenic flexure, where the transverse colon bends inferiorly and becomes the descending colon. And finally, we have the rectosigmoid junction. And unlike the flexure, this is not really like a bend, but more like a transition zone that between the sigmoid colon and the rectum. And before we move on, I want to talk about these watershed areas. And so these are regions of the bowel that receive the dual blood supply from 2 large arteries. And because they're at the edge of both blood supplies, the blood flow is relatively weaker compared to the rest of the colon. And the main watershed areas are the splenic flexure and the rectosigmoid junction. Moving on to arterial supply of the colon, it's divided mainly between 2 major vessels. So we have the superior mesenteric artery and the inferior mesenteric artery. So the superior mesenteric artery supplies the midgut, which is from the cecum all the way to 2/3 of the transverse colon. And the inferior mesenteric artery supplies the hindgut, which is from the distal third of the transverse colon to the upper part of the rectum. So branching off from the superior mesenteric artery, we have the middle colic and the right colic artery and the ileocolic artery. From the inferior mesenteric artery, it branches into the left colic artery and the sigmoid arteries, also the superior rectal artery. And along the edge of the colon as well, if you can see my pointer here, we also have the superior and inferior mesenteric arteries actually anastomose here, which forms a continuous arterial network called the marginal artery of Drummond. So this provides a collateral blood supply for the colon. But does anyone know what the problem might be with this anastomosis between the 2 main arteries? Joe, do you want to help out?
Yeah, is it collateral circulation? Or sorry, marginal. Earlier you were referring to the marginal artery of Drummond, right?
Yeah. But
Mm.
what would a problem be with having this anastomosis?
Anastomosis. They're could prone to hemorrhage, or like this because it's a watershed area as well.
Yes, exactly.
Mm.
Because this anastomosis is the distal ends of both of these major arteries, which is the superior mesenteric and inferior mesenteric artery. So if there is anything, then the blood will have to travel a long distance to reach these specific points, which are also called the watershed areas, which we just talked about. So these parts of the colon are more vulnerable to ischemia, and hence why ischemic colitis often affects these watershed areas first.
Indeed. Sorry, someone has a question as well. So,
Mhm.
Roberto is asking, is the lower border of the hindgut the pectinate line?
Lower border of the hindgut. I think below the pectinate line has another embryological origin, but the hindgut is from the distal third of the transverse colon to the upper rectum.
Mm.
Yep, let's move on. And so moving on to venous drainage, it follows a similar pattern to the arterial supply, and it ultimately drains into the portal system. So everything goes into the liver. And again, we have the midgut draining into the superior mesenteric vein. The hindgut drains into the inferior mesenteric vein, which then joins the splenic vein. And together, the splenic vein and the superior mesenteric vein would then form the hepatic portal vein, which enters the liver. And this allows all the toxins absorbed from the colon to be processed by the liver for detoxification. And this is also why colorectal cancer tend to metastasize to the liver first, as the tumor cells travel via the portal vein. Now let's look at lymphatic drainage. Because we divide the gut into foregut, midgut, and hindgut, this helps us to predict the lymphatic drainage. If we focus only on the large bowel, everything in the midgut will go into the superior mesenteric nodes, labeled as number 3 here. And for the hindgut, everything would drain into the inferior mesenteric nodes, labeled as number 4 here. The superior mesenteric nodes will pass into the intestinal trunk and onto the cisternal chyli, and where it ultimately empties into the thoracic duct, and it will then bring all the lymph through the thorax and drains into the left venous angle. However, the inferior mesenteric nodes follow a slightly different pathway, as we can see here. So instead of joining the intestinal trunk directly, it travels laterally and drains into the left lumbar trunk, and before eventually reaching the cisternal chyli and thoracic duct. Moving on to nerve supply of the bowel, the GI tract has its own intrinsic nervous system called the enteric nervous system, which works independently of the brain and spinal cord. It controls our daily functions like peristalsis and also local reflexes and secretion. There are two main nerve plexes within the enteric nervous system, which are the myenteric plexus, which controls gut motility and movement. And we also have the submucosal plexus, which controls secretion and also local blood flow. So even if all the external nerve input were cut, the gut will still be able to move and also secrete because of our enteric nervous system. We also have input from our autonomic nervous system, which adjusts gut activity depending on our body's needs. So, whether our body is in a resting state or under stress. The parasympathetic nervous system is responsible for stimulating digestion. Therefore, it increases bowel motility and also secretion, helping food move through the gut to be properly digested. It is supplied by the vagus nerve and also the pelvic splanchnic nerves, which supplies the midgut and hindgut respectively. In contrast, the sympathetic nervous system reduces our gut activity, hence why stress and pain can sometimes lead to reduced bowel movements because our sympathetic nervous system suppresses digestion. Innervation comes from the thoracolumbar region of the spinal cord, which then travels through the ganglia before reaching the gut. Next, I want to talk about hemorrhoids and anal fissures because they often get mixed up. And so, to differentiate between the two, first we should identify a critical anatomical landmark. As someone mentioned, it's the pectinate line. This divides the anal canal into two very different regions with different embryological origins and also different nerve supply and epithelium. And this also explains why some anorectal conditions are painful and some aren't. So above the pectinate line, the area is lined by columnar epithelium, which is similar to the lining found in the rest of the colon. And this region is supplied by visceral autonomic nerves. So this type of innervation doesn't transmit pain very well. So a patient might not be as sensitive to pain if there's a cut here. And internal hemorrhoids arise from the internal hemorrhoidal plexus, which is located within this region. And hemorrhoids are basically these abnormally dilated veins that form when the veins in that plexus become stretched or swollen. And because of the visceral innervation, they usually present with painless and bright red bleeding during or after defecation, but they usually don't complain of pain. And below the pectinate line, the lining becomes stratified squamous epithelium, like our skin. And this area is innervated by somatic nerves, which is it's primarily via the pudendal nerve. And this region is highly sensitive to pain in comparison to the region above the pectinate line. It's also sensitive to touch and temperature. So external hemorrhoids arise from the external hemorrhoidal plexus that's located below the pectinate line. And because of this somatic innervation, they're often very painful, especially when they become swollen or thrombosed when blood clot forms within the hemorrhoids. So anal fissure is another common and painful condition that's found below the pectinate line, and they typically present with severe and sharp pain during and after defecation, along with a small amount of bright red blood sometimes. And the pain can last for hours after opening the bowels. And some other important conditions to distinguish are anal abscess, which is a painful collection of pus that's caused by an infection near the anus. Anal fistula, which is an abnormal canal or tract that forms usually between the anal canal and the perinatal skin. And they usually develop after an abscess that has drained or healed poorly. So if the abscess doesn't resolve fully, the infection leaves behind a tract, which becomes a fistula. So going back to our case, once we've taken a history and an examination, we could do a blood test as our next step. We can do an FBC, which tells us the hemoglobin level and helps us to determine whether the patient is anemic. So in patients with chronic GI bleeding like Mr. Thompson, we are particularly concerned about iron deficiency anemia, as persistent blood loss can deplete our body's iron stores. And the FBC might also review microcytosis. So these are just abnormally smaller red blood cells, and these will show up as a low mean corpuscular volume, MCV, on the blood test, which is highly suggestive of chronic blood loss. Next, we have the inflammatory markers. CRP and ESR are both indications of inflammation or any underlying pathology like malignancy. Moving on to stool studies, these are non-invasive screening tests that's used to detect occult blood in stools, which are, as we mentioned earlier, these are hidden and not visible to the naked eye. So starting with fecal occult blood tests, this test detects the presence of blood via a chemical reaction. However, the test is not specific to human hemoglobin, so things like red meat or certain vegetable and medication can affect the results and give us a false positive result. And because of that, patients need dietary restrictions beforehand to ensure the results are accurate. A fecal immunochemical test FIT, on the other hand, uses antibodies to detect human hemoglobin. So this makes it more specific to detecting bleeding and gives us a more accurate result overall. And it also doesn't require any dietary restrictions, which improves patient compliance. And for these reasons, FIT has largely replaced FOBT as the preferred screening tool. It's also important to note that a positive result from both tests doesn't always mean colorectal cancer or cancer, because it simply indicates that blood is present, but it also requires further investigation. And in most cases, the next step is a colonoscopy, which allows a direct visualization of the colon and also biopsy and treatment. So, as I said, a colonoscopy is the gold standard investigation for lower GI bleeding and other colorectal conditions, as it allows a direct visualization of the entire colon, and you can perform a biopsy and also treatment if you identify pathology like a polyp. So you can remove them during a colonoscopy and before they develop into cancer. In some cases, flexible sigmoidoscopy may be used instead, in particular when bleeding is strongly suspected to originate from the rectum or the distal colon. It's a much quicker procedure compared to colonoscopy, and it requires less extensive bowel prep and sedation. However, since you cannot visualize the entire colon, you may miss some pathologies that are higher up in the GI tract. So, when a colonoscopy is contraindicated or poorly tolerated by the patient, for example, if they are at a high risk of perforation or if they are unfit for sedation, then a CT colonoscopy may be considered instead. So, it's a CT scan that creates a 3D image of the colon. It's performed by first insufflating gas into the colon to distend it, and then you do a CT scan. And a lot of patients actually prefer this because it doesn't require inserting a scope in the colon, so it's less invasive. And it can also detect polyps and masses, but we can't take any biopsies or treat it if we found any polyps. It's also not typically used in acute lower GI bleeding because it doesn't allow immediate treatment like a colonoscopy. Similar to a colonoscopy, it requires a bowel prep, which includes taking a laxative the day before and also a contrast dye the day before or even in the morning of the scan. But the difference here is that it doesn't usually require sedation, so patients can resume with their normal activities soon after the procedure. However, it also has a low risk of complication. No, sorry. It also has a lower risk of complications compared to a colonoscopy, particularly a perforation. I've got a short video here that shows us how a CT colonoscopy is done. It's basically a fly through showing how a 3D view of the colon is created, but we might not have enough time to watch it now. And I know that these slides will be sent to you afterwards, so maybe you can watch it in your own time. So, moving on to management strategies. For colorectal cancer, initially, patients are referred urgently under a 2-week wait pathway, and they will undergo a colonoscopy with biopsy, usually to confirm the diagnosis, followed by a CT scanning of the chest, abdomen, and pelvis for staging and to look for any metastases. Definitive management is mainly surgical resection. Also, depending on the stage, the patient may receive chemotherapy afterwards. And in rectal cancer, especially, radiotherapy is often used before or after surgery to reduce any local recurrence. Since the rectum is fixed in the pelvis, it can be targeted more accurately with radiation in comparison to the colon, which is more mobile and also less suitable for radiotherapy. We also have supportive management, which includes stoma formation if needed, and also palliative care in patients with advanced or metastatic disease. So here are some complications of diverticular disease. again, a quick recap: diverticular disease is a very common condition that affects the sigmoid colon usually, and it's very crucial to differentiate between the types of diverticular disease, which are diverticulosis and also diverticulitis. So diverticulosis is the benign form compared to diverticulitis. It's the presence of one or more diverticula, which are these small bulging pouches of the colonic mucosa through the muscular wall of the colon. And most people with diverticulosis are asymptomatic, so you would just leave them be and it shouldn't cause any problem. However, complication like a lower GI bleed may happen, especially when the blood vessels supplying the colon wall rupture at the neck of the diverticulum, and this would usually present as a bright red blood through the rectum. However, things become more concerning when one or more of these diverticula become inflamed or infected, in which we call this diverticulitis. And this inflammation can lead to further complications like an abscess, perforation, or peritonitis, or even a fistula. So now that we've covered the complications, I want to talk about some management strategies for diverticular disease. And how we manage it depends on whether the patient has asymptomatic diverticulosis or uncomplicated or complicated diverticulitis. So, starting with diverticulosis, for those who are asymptomatic, they generally don't require treatment, as I mentioned. But for those with symptoms, the focus is largely on prevention and also lifestyle modifications, like a high fiber diet, drinking more water, and lifestyle advice is also important, and for example, maintaining a healthy BMI and also engaging in regular physical activity can also help reduce the risk of developing diverticulitis. And finally, reassurance is key. As I mentioned, diverticular disease is very common, and so educating patients about its nature and how to prevent complications is very important. Next, we have uncomplicated diverticulitis. This means that there's inflammation of the diverticula, but without all the complications that we mentioned earlier, like an abscess or a perforation. And around 85% of acute diverticulitis cases are uncomplicated. So the traditional approach was always to give antibiotics, but in recent guidelines, including the NICE guidelines, the emphasis is more on conservative management as the first line approach. This includes giving pain relief. Also, patients are often advised to start with a clear fluid or a light diet to allow the bowel to rest and also reduce irritation. If the symptoms don't improve from conservative management, we would consider oral antibiotics such as amoxiclav for 5 to 7 days. If that doesn't work too after 72 hours, then the patient should be admitted for IV antibiotics. And at the top end of the spectrum, we have complicated diverticulitis, and this is when the inflammation has led to complications that we just discussed, like an abscess, perforation, fistula, etc. And this is a lot more serious in comparison to diverticulosis and uncomplicated diverticulitis. Therefore, it requires more aggressive management. So IV antibiotics can be given. Fluids are often given as well. And a CT scan of the abdomen can also help stage the disease and identify any complications like abscess or perforations. So if an abscess is identified, especially a larger one, then percutaneous drainage can be performed in conjunction with the antibiotics. So surgery is usually reserved for very serious or complicated cases, such as those with peritonitis caused by the perforation, or when conservative and interventional management fails. So in the case of surgery, a Hartmann's procedure may be done where a diseased section of the colon is removed and a temporary colostomy is created. But this usually happens in an emergency setting where an obstruction is needed to be removed to stop any infection or cancer before it spreads. So moving on to IBD management. Starting with ulcerative colitis, which typically affects the colon and the rectum, and it also has continuous inflammation. The treatment for ulcerative colitis usually starts with inducing remission, especially in mild to moderate active disease. Oral and or rectal aminosalicylate acid is used to reduce any inflammation in the colon lining. And you can start with topical rectal acid. If that doesn't work, then you can add on the oral acid. For patients with moderate to severe flares, if they don't respond to the acid, then you can give them corticosteroids. And to maintain remission, oral acid is continued for the long term to prevent any relapse. And for patients with steroid refractory disease, meaning they don't respond well to corticosteroids or if they have become dependent on them, they would typically move on to more potent immunosuppressive therapies like immunomodulators or biologics. But we'll discuss some more examples on the next slide. A critical distinction between ulcerative colitis and Crohn's is that colectomy is curative, since ulcerative colitis is confined to the colon and the rectum. So by surgically removing the entire diseased colon and rectum can resolve the disease. On the other hand, Crohn's can affect any part of the GI tract, and patient often presents with skip lesions, which are these patchy areas of inflammation that are separated by segments of healthy tissue. And also, they may also present with transmural inflammation, meaning the inflammation is affecting all layers of the bowel wall. Hence why the management is different compared to ulcerative colitis. For inducing remission, corticosteroids are used in active Crohn's flares due to their rapid anti-inflammatory effect. Oral corticosteroids like prednisolone are also commonly used, but if the inflammation is limited to the ileum or the right colon, then budesonide is preferred since it's gut selective and therefore it will have less systemic effects. To maintain remission, immunomodulators or biologics are the mainstay therapy to prevent any flares and also disease progression. And unlike ulcerative colitis, surgery for Crohn's is typically reserved for complications such as strictures or having a fistula. This is because surgery for Crohn's is not curative. So even after a surgical resection is done, it often reappears, especially in areas adjacent to the surgical anastomosis. And so patients often require continual medical therapy even after the surgery to prevent any recurrence. Supportive care is important for all IBD patients, whether they have ulcerative colitis or Crohn's disease. Smoking is a known risk factor that significantly worsens Crohn's disease, so smoking cessation is very important here. For ulcerative colitis, the relationship with smoking is more complex. So some studies suggest that it may be protective against disease risk, and by stopping smoking, it may actually increase the risk of a flare. But given the overall detrimental health effect of smoking, cessation is still usually recommended for all IBD patients. Nutritional support is also important because patients with IBD usually suffer from malabsorption and also increased metabolic demands due to inflammation. And they also have an increased risk of developing venous thromboembolism, and therefore giving them prophylactic anticoagulation may be considered to prevent any clots from forming. And patients with long-standing and extensive IBD are at an increased risk of developing colorectal cancer, and therefore regular surveillance colonoscopy is important for early detection and also treatment. Building on our discussion of management strategies, now let's take a look at some pharmacological treatment for IBD, starting with anti-inflammatory medicines. As I mentioned, ASA, like mesalazine, it's a key example. They are primarily used for mild to moderate ulcerative colitis. They work topically on the bowel lining to reduce inflammation. However, they have very limited role in Crohn's disease, since Crohn's can affect the small bowel as well, and so these drugs might not reach effectively. Also, the transmural nature, which affects the whole all the way through the bowel, the inflammation often requires a deeper acting drug for Crohn's disease. Corticosteroids are also often given to induce remission in moderate to severe flares of both ulcerative colitis and Crohn's disease, and they provide a rapid anti-inflammatory effect by suppressing the immune system broadly. However, they are not for long-term maintenance because of their significant side effects. Next, we have immunomodulators, and these are used for maintaining remission, usually, especially in Crohn's disease. However, they have a much slower onset, and they take several weeks, up to a month, to become fully effective. Next, we have methotrexate. Is an antimetabolite that's primarily used in Crohn's disease when other therapies don't work, or if the patient cannot tolerate thiopurines. Like other immunomodulators, methotrexate has a very slow onset as well, and also has side effects like bone marrow suppression and liver toxicity, and therefore it requires really careful monitoring. Finally, we have more targeted therapies like biologics, and most biologics in IBD are monoclonal antibodies, sorry, and these are often reserved for moderate to severe IBD that hasn't responded to the conventional therapies. So we have anti-TNF agents. Infliximab is commonly used in hospitals these days, and it's highly effective in treating moderate to severe IBD. We also have anti-integrin agents and also anti-interleukin agents. They're both used to reduce inflammation. And you can also combine biologics and also immunomodulators in order to boost the effect, especially for more severe active IBD. Now we have management strategies for hemorrhoids. The first line is usually conservative management and also lifestyle modification, especially for grade 1 internal hemorrhoids. For those who are not familiar with the grading for internal hemorrhoids, there are 4 grades, with grade 4 being the most severe. And so conservative management includes increasing fiber and fluid intake, also avoid straining if possible. You can also give them topical corticosteroids and pain relief. But these conservative management also applies to external hemorrhoids as well, so not just internal hemorrhoids. And when these are not sufficient, then we can move on to procedural interventions that are typically used for grade 2 and 3 internal hemorrhoids. And this includes a rubber band ligation, where you place a small rubber band around the base of the hemorrhoid, and the band will cut off the blood supply, and the hemorrhoid will then necrose and fall off in a few days or up to a week. So sclerotherapy is another option, where a solution is injected directly into the internal hemorrhoid to shrink it. And it's a simple procedure, and it doesn't require any anesthesia usually. And finally, in severe cases such as grade 4 internal hemorrhoid, where they stay permanently prolapsed and they cannot be pushed back in, then a hemorrhoidectomy may be considered to remove them. And again, this applies to both internal and external hemorrhoids. Management strategies for anal fissures. It's essentially a small tear or an ulcer in the lining of the anal canal, which can be quite painful, especially during and after bowel movements. So usually you would start with conservative approach as well, especially for acute anal fissures. And this includes having a high fiber diet, increased fluid intake. You can also give them laxatives if required, pain relief, and also taking warm bath will help as well. However, if the symptoms persist for more than a week, then we can move on to more pharmacological approach. And often a topical GTN is given like a topical GTN ointment is given, or you can give them diltiazem, which is a calcium channel blocker, which works by relaxing the internal anal sphincter and reduces any muscle spasm. If these approaches are unsuccessful, then we can consider more advanced interventions like giving botulinum toxin injection, or we can consider surgery. The treatment for colorectal cancer now is very complex and highly individualized depending on the stage of the cancer and its location of the cancer. So let's begin with some early stage procedures, starting with, sorry, just one second. Yep, starting with early stage procedures. The goal here is to remove the cancerous or precancerous lesion while preserving as much of the normal tissue and function as possible. And these are often curative for very early cancers. So the first and most straightforward procedures are a polypectomy or a local excision. And for polypectomy, the cancer is removed as part of the polyp during a colonoscopy. So a wire loop will pass through the colonoscope and to cut off the polyp off the wall of the colon with electric current. However, for larger and flatter lesions, a local excision might be performed instead. And for larger early stage polyps that are still confined to the superficial layers of the bowel, an EMR might be used. So this involves injecting a solution, usually a saline solution, under the lesion to lift it up. So this lifts it up from the muscle layer, and then you can use a wire snare again to place it around the lesion and cut it off with electric current. And however, when cancer has invaded deeper into the bowel wall or when it involves nearby lymph nodes, then a colectomy may be performed. So the goal here is to remove the diseased bowel segment and also nearby lymph nodes. And the type of colectomy depends on the tumor's location. We can have a right or left hemicolectomy, which is the removal of the right or left half of the colon, as we can see on the diagram on the right. And a sigmoid colectomy is a removal of the sigmoid colon, and a total colectomy is used in rare cases where there are multiple cancers in different parts of the colon. And this involves removal of the entire colon, and it may or may not include a rectal preservation. So if the rectum is removed as well, then it will be a total proctocolectomy, but if we want to preserve the rectum, it would be a total abdominal colectomy. For very low rectal tumors, particularly those that are very close to the anal sphincters, an abdominal perineal resection might be done. And also, finally, we also can give them a chemotherapy or a radiotherapy to enhance the effectiveness of the surgery and to prevent any recurrence. So now I'd like to talk about some different types of stoma. So a stoma is a surgically created opening on the abdomen that allows for the discharge of bodily waste, primarily from our bowel or our urinary tract. It's really useful to be able to recognize these on the ward, so I highly recommend getting familiar with these. The first thing you can differentiate is to differentiate whether it's an ileostomy or colostomy. As hinted in their names, an ileostomy involves the ileum, whereas a colostomy involves the colon. So an ileostomy is typically located on the right side, and specifically the right iliac fossa, whereas a colostomy would be on the left, but that can vary too. And you can also differentiate between an ileostomy or colostomy just by looking at the bowel, because an ileostomy tends to be spouted, so the bowel would protrude slightly from the skin. The stoma would be more protruding, and whereas a colostomy is described as flushed, so it's more flattened, as we can see here is an example of a, a colostomy. And here are three primary types of stoma. For an end stoma, the bowel is fully divided with only one lumen brought to the surface of the skin as the stoma. And the distal end of the bowel is either surgically removed entirely, or more commonly, it's just closed and left inside the body. And it can be temporary or permanent, and although it's more likely to be permanent. And from a patient's perspective, an end stoma is often considered the easiest type of stoma to manage because it's only got a single opening. And however, a stenosis is a common complication of having an end stoma, which as a result of extensive scar tissue, which then narrows the single lumen opening. Next, we have loop stoma, which you can see on the image. A single stoma is formed with two openings. So this is usually done by bringing a loop of bowel onto the surface of the skin. And it's typically temporary rather than permanent, because this is usually done when you want to let the rest of the bowel below the loop to rest or heal before having all the digestive food to pass along the bowel. And so you also want to protect a distal anastomosis. So a loop stoma is very common, and it likely indicates that they've had an anterior resection. But this is usually reversed later on once everything has healed properly. And finally, we have the double barrel stoma, which is less commonly done these days. And the bowel is completely divided with two adjacent separated stoma. And both ends are brought to the surface, usually side by side, with a small strip of the skin separating them. And the proximal ends usually pass stool, while the distal end drains mucus. And it's usually temporary, but it could be permanent in palliative cases. And finally, I want to talk about bowel cancer screening in the UK. So, colorectal cancer is the third most common cancers in the UK, and also the second most common cancer of death. And so, early detection through screening can significantly improve outcomes. In the UK, bowel cancer screening includes a fit stool test, as we just talked about, and you'll receive that by post. The invitation ages in England, Scotland, and also Wales start from 50 to 70 years old, whereas in Northern Ireland, the invitation age start from 60 to 74 years old. However, I'm aware that this will change soon to 50 to 74 years old, like the rest of the UK. And this test is offered every 2 years to asymptomatic individuals. And as we talked about earlier, a FIT detects hidden blood in the stool based on an antibody antigen reaction that's specific to human hemoglobin. However, a positive test doesn't always mean bowel cancer, but it simply means that there's blood detected in the stool. And then they are usually, patients usually referred to a 2-week wait pathway for a colonoscopy for further investigation. And other benign conditions can also cause a positive reading on a FIT test, like hemorrhoids and also inflammation. And so a positive test doesn't always equal to bowel cancer. And that brings us to the end of the session. Thank you, everyone, for joining. I've gone over time a little.
Uh, um, okay. So hi everyone. I've just sent the feedback form into the chat. So really appreciate if you guys can take the time to fill it up. As it will be means a lot to Yunbi, and also will help us to understand where we can improve better in the future as well. So I want to say really thanks a lot to Yungi. It was very comprehensive and detailed presentation where she covered a lot of higher topics, um, and things that she mentioned like you guys need to take notice of, particularly when it comes to lower GI bleed. That can be important. I don't see QR code via email. Hi Eva. So we don't need the QR code anymore. We will be purely using this feedback form. Feedback form. Sorry, I see the link. Oh, okay. Yeah. If you fill up that feedback form, it's more than sufficient. Yeah. Thanks, Sophie. Yeah. In the meantime, if you guys have any questions at all, now is the time to ask. So don't hesitate to ask at all. Yeah, as Yumi is very knowledgeable in this topic. Yeah. So yeah. Oh, thanks, Razu. Good night. Yeah.
Thank you, everyone.
Yeah.
I think everyone should go get some dinner now.
Okay. Mm. Mm. See a few people, but I think yeah.
Mm.
Uh, Ghana, okay. Yeah, I think everyone left already. But really, thanks a lot, MB, for today. Yeah.
Yes, thank you for facilitating the session.
Ah, sorry. Yeah, it's always try to engage everyone a bit more, but yeah, sometimes it can get a bit difficult. But yeah, you did very well, and then yeah, it was nice presentation.
Thank you. I might have rushed a little bit because
Uh,
there's so much to go
yeah, yeah,
through.
but I think it's okay because actually I think the content itself is quite heavy to put in 1 hour alone, and
Mm,
you managed to do that. So yeah, so it's you even cover all different type of stomas. So yeah, that's really good.
mm,
Thanks, Naima. Uh, mm, I'll send the probably will give them a a day or so to fill out the feedback form first. Then I'll after that I'll email you the feedback responses lah. Will that be okay?
yeah, perfect. Thank you so much.
Okay. Yeah. Did you take a long time to prepare these slides or?
A little bit, yeah.
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 But because like out of all the because I sent out all the tutor slides to patrons. So
Mm.
yours is the only one that comes back by the patron.
Oh, really?
Great,
Oh,
great
wow.
job. Well done. Yeah, that's why. Yeah, to you because yours
Thanks.
only, not only includes like all the details, got pictures as well. So
Mm.
yeah, it's quite really nice. Fun. Yeah.
What are other people's slides like? Then did they not include like pictures?
uh, yeah. So like some of them they put a lot of contents, a lot of words in it, so it's very word heavy. Otherwise, it's not really too surgically focused,
Right.
or it's um the the content is uh doesn't really cover the high yield topics. So it's really a mixture of that. Yeah.
Mm.
Mm.
I'm sure I'll get better.
Yeah, definitely. Mm. You're also in PeaceNet, right? You mean?
Yes, yes. And is Agna in SUPTA as well?
Yeah, that's why initially I saw, how come all of us are
Did you know her before? Like,
Um, no, because because the thing in SUPTA is the research leads they for some reason why I'm not too sure, but the research leads they don't really get involved in SUPTA's operating.
Mm,
Hence why the national committee and also regional reps we don't really come into much contact into them because they're more focused on they follow up directly with one of the board members, which is Eamon.
mm,
Yeah, so I haven't really uh I don't really know Akna much because I haven't really talked to her before as well. Yeah.
mm. Honestly, I don't know how you guys manage. Yeah, it's so much work, like for your role.
Yeah, it's difficult. Are you interested next year? You can take over my role.
What is you honestly?
Yeah, I mean, yeah, still early. So actually now you're in preclinical
I am.
phase.
Mm.
Oh, but do you go on placements or
We do have some GP placements,
oh
but not so much at the hospital. We do
mm,
have like, one or two sessions, but not that much.
okay.
Yeah.
But next year onwards, then you guys will start to go to the hospital. Okay.
Yeah.
Yeah.
Uh, is there anything else?
No, yeah, I think yeah. Yeah, you can if you want to leave, you can yeah, you leave now. Uh,
Okay. Well,
yeah, please.
will the attendees get sent the slides, or do they have to download it like from?
Yeah. So what I did actually was actually prior to this session, I've already uploaded your slides on
Mm.
Career Book, so they should be able to access it as well. But I'm not sure whether they saw it. Hence, after this, I will email them the slides as well.
Okay, right.
Yeah.
And the recording will just stay on Career Book, or would it be?
Yes, the recording will stay on Career Book,
Oh,
but we will possibly upload it onto the website as well, like our Subtas website.
oh, okay, but
Yeah.
not like YouTube, right? Because I noticed it's uploaded on YouTube last year.
Yeah. We might upload it on YouTube as well.
Ah, okay.
Would it be okay?
Okay.
Yeah.
Sure.
Yeah.
Okay. Thank you, Joe.
Yeah. No worries.
Speak soon.
Thanks a lot, Invi, for today.
Please get some dinner.
Thanks. You too.
I'll see you. Bye.
Bye.